Hello, welcome to this session, and here we are going to discuss coronary vasodilators in management of chronic coronary syndrome. Basically, chronic coronary syndrome includes a wide spectrum of disorders which include patients who have had coronary syndrome or heart attacks in past but are no more having current ongoing acute coronary event. This also includes patients who have MINOCA, which is myocardial infarction of non-obstructive coronary disease, or angina of non-obstructive coronary disease. And CACS is a wide spectrum of disorder where treatment strategies would include not only beta blocker, statin and antiplatelet, but also vasodilators. Lot of times it's the nitrates that have been used, and I'm going to talk about dilator therapies including nicorandil in the management of the same. So basically CCS encompasses pathological condition which produce chronic or repetitive mismatch between demand and supply of myocardial oxygen. Causes of ischemia most commonly is the atherosclerotic obstruction. However, less functionally, you may have microvascular dysfunction, vasospasm, congenital anomaly, or non-atherosclerotic myocardial injury, which is characterized primarily by presence of angina. The basis of treatment hence includes not only healthy lifestyle and behavior and cardiac rehab, but also antithrombotic therapy, revascularization, lipid-lowering drugs and anti-ischemic therapy. This is the anti-ischemic therapy is hence one of the most important pillar in the treatment strategy. The beta blockers and calcium channel blockers have very often been the first line of agent to reduce angina, but they have not shown any survival benefit. The second stage is, or the second line of drugs includes long-acting nitrates and nicorandil. Short-acting nitrates are only used for the emergency rescue of angina purposes. Hence, the role of vasodilators would primarily be focusing on long-acting nitrate versus nicorandil. So when you compare goals of vasodilator therapy, we have two important goals to achieve. One, symptom relief and improvement of functional capacity, and second, to prevent further CV events and mortality. So vasodilators have been used for decades, as I mentioned, along with beta blockers and calcium channel blockers. The long-acting nitrates basically are vasoactive nitric oxide releasers. In low dose, they cause venodilatation and reduction in the preload. Also, the reduction of preload apart and venous return volume and myocardial tension reduction. At higher doses, they can only dilate coronaries, improve subendocardial perfusion, decrease ventricular diastole and lower blood pressure. But the long-acting nitrates have a limitation in terms of endothelial dysfunction, development of tolerance, pseudotolerance and tachyphylaxis, which means a long-acting nitrate will become not of use beyond couple of days. From clinical trials, we know, including large registries, that even 18 months of therapy in patients with healed MI that is associated with actually increased recurrent coronary events with no CV reduction. In JCAT study, who had significant stenosis, at least one coronary, and 2.7 years of follow-up, nitrates had 15% increase in the adverse event rate. So there is very limited data in microvascular dysfunction or microvascular angina because of its relatively small vasodilatory effect on small resistance vessels. In a meta-analysis, long-acting nitrates are not superior to the other anti-anginals like ranolazine or ivabradine in improving symptoms and functional outcomes. Nicorandil, however, has been a unique drug because of its anti-anginal effect with dual mechanism of action. It acts not only primarily by opening the NAK-ATPase pathway, but also the nitric oxide pathway. So roughly mathematically put, you can say nicorandil is equal to nitrates plus NAK-ATPase. The NAK-ATPase will inhibit the calcium tone and also reduce the calcium in the endoplasmic reticular release, and also prevent the cell apoptosis by the other pathways that may include mitochondria. Like a typical nitrate, it also is responsible for medium to large vessel vasodilatation, but ATP-K-ATPase inhibition leads to microvascular dilatation. Hence, it's proven in both patients with coronary spasm as well as microvascular disease, typically in challenging patient population. So unique features are not only ischemic preconditioning by cardioprotection, which is classically a phenomena when a repetitive ischemia episode ensues. It protects against the subsequent prolonged ischemia and hence it can reduce infarct size. For example, a young athlete, when he develops a sudden acute MI while playing cricket, he is very likely to die of it because of the no ischemic preconditioning in such a patient. However, a patient who is case of coronary artery disease and has been on nitrates for long, and if he has a 90% stenosis over say 1 or 2 years with repeated angina, he ends up with an MI, the likelihood of the MI being fatal is less. This is the phenomena of ischemic preconditioning. Nicorandil, because of its mechanism through KATP agonism, actually mediates the ischemic preconditioning pathways. Hence, nicorandil is not only vasodilator but is also cardioprotective and also has been hypothesized to reduce the atherogenesis and reducing endothelial dysfunction. So it's the only anti-anginal now with reduction in hard CV endpoints, which is the trial and database as from the IONA study. This was published way back in 2002 in Lancet, where they looked at the reduction of CHD deaths, non-fatal MI, unplanned hospitalization for chest pain by 17%. More importantly, all cardiovascular events were reduced by 14% and ACS by 21%. IONA concluded that this pathway reduces preload afterload and has anti-anginal efficacy which is similar to oral nitrate beta blocker and potential for cardioprotective action. This study patients had primarily more than 10% with age more than 60 and 2 to 5% between 40 to 60 years of age. Another study, JACAD, actually looked at 2,500 plus patients for all-cause death, and it showed there was 35% reduction in all-cause death, which was lower as compared to the control arm in patients with CAD in actual clinical practice. Cardiac death was reduced by 56%, fatal MI by 56%, and cerebral and vascular death by 71%, and also heart failure by 33%. Hence, nicorandil in this study in the JCAD showed large patients with IHD with implications for treatment. So, cardioprotective effect of oral nicorandil in diabetic patients undergoing PCI has also been studied with 20 mg followed by 6 months in a paper from Egypt, which shows decreased incidence of PCI related injury and improvement of ejection fraction. OCIS trial looked at the prospective multicentral 5-year plus data sets of nicorandil with reduced incidence of death for secondary prevention. This was true across the subgroup with regression analysis revealing nicorandil treatment to be associated with reduction in all-cause death after discharge. Nitrate titration versus nicorandil, as we know, is much easier compared to nitrates. Nitrates will not circumvent the need to start nicorandil. If the patient is on nitrate tolerance, or to avoid tolerance, nitrate-free interval is required. Hence, there may be rebound angina. But this is not the case with nicorandil. It does not have any tolerance, no cross tolerance, no endothelial dysfunction, and no rebound angina. So, to summarize, between the two therapies, long-acting nitrates are vasodilators. Nicorandil is so as well, but it has an additional mechanism of KATP channel opener. It also dilates microvessels, has cardioprotective ischemic preconditioning, does not cause potential steal phenomena. Also, there is evidence in improvement in microvascular dysfunction without any concern for tolerance, endothelial dysfunction, and there is evidence of CV reduction in these patients. So this is the summary of trials comparing nitrates with nicorandil, and that's the topic of the day, where I have summarized two important vasodilators that are used in patients of CCS, nitrates and nicorandil, apart from the standard care of beta blocker, dual antiplatelet when indicated or single antiplatelet, and statins. Thank you very much. Stay connected for more learning across to our channel. Take care. Bye-bye.